Good evening and welcome to On Call with the Prairie Doc. Modern healthcare involves many sciences: the chemistry of pharmacy that provides drugs that help battle disease, the biology of maintaining a healthy body with exercise, nutritional science showing us the way of a healthy diet. Surgery might be called the procedural side of healthcare, the actual process of draining an abscess, cutting something bad out. It may be setting a bone or opening and or bypassing an artery that doesn't flow as it should. Tonight, we visit the surgical suite. First, let's take a look at this week's Prairie Doc quiz question. The best treatment for an infection that has collected into a red, hot, swollen, painful, inflamed boil is, number 1, antibiotics and cold compresses. Number 2, a knife into the pocket of pus and hot compresses. 3, massage and crystal therapy. Call or email your answer now, and we'll take quiz answers for only 10 minutes. Viewers who call in the correct answer will be entered into a drawing or win a signed copy of A Picture of Health. This book was written by me and accompanying photographs by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in, and we answer your questions. We want your questions as they are called in or sent to us via Facebook or email, or call in your questions to 1-888-376-6225 or send us an email. Joining us tonight is Jeff Johnson of the Avera Medical Group Brookings and Gary Timmerman, the head of surgical residency program at USD Stanford School of Medicine. Welcome both of you to the show.
Thank you.
Jeff, tell us a little bit about where you're from and your training and your experience and a little bit about you.
Sure. Well, I grew up in out west in Colorado. And
So you're a Colorado boy.
Yes. I went to college initially in North Dakota, which is where I met my wife and gained my ties to the area. Her family now lives in Sioux Falls.
You were going to be an airplane pilot.
Yeah, I plan on being a professional airline pilot, yes, and I still fly rarely. But decided to change my mind, went back to the University of Colorado, and eventually attended medical school for a brief period of time in the Caribbean, and then I spent most of my training in Kansas City, where I did second half of medical school and stayed for surgical training. And I practiced in Colorado briefly and then came up here.
And we're so glad to have you in Brookings, South Dakota.
I'm thrilled to be here.
And it's great to have, everything he touches seems to turn gold, as we like to say. So, Gary, you're originally from Watertown.
Watertown. Born and raised in Watertown. I'm a South Dakota product.
Where did you go to undergrad?
Undergrad at SDSU, and then medical school for a couple of years at University of South Dakota, and then Washington University in St. Louis. I did my surgical training at Rush in Chicago, always with the intent, absolutely with the intent to come back to my home state. And went back to Watertown and gave back to the community that gave me so much, and practiced there for 10 years, and then moved to Sioux Falls about 18, 20 years ago, and I've been in Sioux Falls since.
Were you at the Bartron Clinic or the Brown Clinic?
The original Bartron Clinic, but in those days, and I still think today, both clinics worked very well together. It really didn't matter the quote-unquote side you were on. Surgeons always help out surgeons, and so actually was recruited by very good friends from the Brown Clinic as well when I went back to Watertown.
Yeah, and I have to say that Bob Bartron, God bless his soul, took me under his wing and tried to keep me in Watertown. I did my MECO summer times when I was in med school in the Bartron Clinic.
He was very instrumental to the state of South Dakota to help us get the four-year med school. He was in the legislature in South Dakota back in those years, and was actually there at the signing when they made it an official four-year school.
Yeah, and I think some of my closest friends are in the Brown Clinic right now up there, so it's a good
and
place.
Me as well.
But you moved to Sioux Falls because?
Well, at the time, I have some advanced training in trauma and advanced training in surgical oncology.
And you wanted to get into that.
And I wanted to get into that a little bit more. And so an opportunity arose that they needed somebody to help with trauma. And so I was the trauma director at then Sioux Valley. and now Sanford, and then did that for 10 years, and then broadened my surgical oncology practice, and then also got involved with the medical school.
And that's how you became the head of the Department of Surgery and the residency program.
Yes, that's correct. And about 3 years ago, was able to get into the position of being the chair of the department, and almost for the last 6 or 7 years, noted that there was such a deficiency in replacing our rural surgeons across the state, and also coming from the land of Chet McVeigh,
Yes.
down in Yankton, South Dakota.
Dr. McVeigh and
we
the
had not
McVeigh-
had a residency here in surgery since 1986. And so the timing was ripe. I will give credit to Sanford. They actually came up with the money for us to do it, as well as all the support and all the faculty that we could do. Also had great assistance with our colleagues down in Yankton, and so a part of our residency is back to the homeland of Chet McVeigh in Yankton, and that's Avera as well, and then also the VA in South Dakota.
Yeah.
So very
Great.
delighted.
Great. And I have to say that I was sitting in at Emory in Atlanta, Georgia, on the surgical rotation as a junior medical student, and they were giving a lecture on how to do the hernia repair, and they said, well, and there was this guy named Chet McVeigh who was an anatomist, and then he went into surgery, and then he developed the hernia repair that we all use, and then he moved to South Dakota, for goodness sake. And I said, that's where I'm from.
Yep.
And the whole group kind of
Absolutely. I was at St. Louis in the exact same scenario where I had to give a talk on a hernia repair and talked about the McVeigh repair. And one of the residents disagreed, and I said, no, it's done this way. And the chairman in the back of the room said, Dr. Timmerman, why don't you tell them where you're from? And I said, well, I'm from South Dakota. And the chair said, Dr. Timmerman is correct. Now, I wasn't in the greatest graces with that chief resident anymore, but I did have very good training from Chet McVeigh.
Yes, you did. Please remember that this is, your calls are what matters to us. And so we want you to give us a call at, the 1-800 number, and or give us an internet message and give us your questions. It's your questions that make this show. So, and you heard of the McVeigh repair?
Oh, absolutely, yes. It's a specific type of hernia repair where the patient's tissues are all used to repair what's a defect in the muscular layer. Nowadays, we really use a piece of mesh or a prosthetic material, kind of a screen, to provide what's called a tension-free repair. And McVeigh actually had that in mind because his repair does release tension by making an incision in one of the layers.
Right. And that's his key deal, wasn't it? It was that you got the relaxation.
Yes.
So let's talk about the history of surgery. When did the surgeons, we all talk about surgery as a different field than medicine. I'm an internist. And there's all the internal medicine-oriented fields, cardiology, nephrology, rheumatology, and so on and so forth. The surgical fields are different, but how did it all start?
Well, there's a strong history in surgery being a barber surgeon. So the barbers were the ones, as I think Dr. Timmerman mentioned earlier when we were discussing this, that they had the sharpest knives. So they had the access to some of the tools that were necessary. And they also were intimately involved in a barber touches a person and a patient, and that was something that
the internist didn't
historical physicians were reluctant to participate in.
Right, so the surgeons versus the physicians is kind of how it went. And the barber pole, what's that story?
Go ahead.
Oh, well, obviously you can't, just like you can't make an omelet without breaking an egg, you can't perform surgery without some bleeding, and the barber would use his rags to mop up the blood and then would wring them out and place them out on the pole outside of his office. So the classic twirling red pole is the barber pole, yes.
So when did this surgical story all begin?
Well, actually, there's been record of surgeons dating back to Hippocrates and also even to Galen in Rome. Galen was actually a Greek who lived in Rome and was one of the physicians, if you will, to the gladiators. And same sort of thing, a lot of taboo. You weren't allowed to touch the body unless the body was dead. And even then, you could do something that would upset the gods. They really didn't want it. So much of medicine there was observation, and then you would take that observation and you could operate on animals. And so you came up with different ideas about process and disease. And I think one of the most interesting things about Galen and Hippocrates were back in the day, if you will, they tried to describe things, again, as we had mentioned, by observation. And there was I'm told, and I wasn't there was a gal who apparently had a breast cancer. And she had died from a horrible breast cancer because, of course, it wasn't removed. And the cancer took over her chest. And in their description, they looked at that, and I think it was Hippocrates actually looked at it and says, that looks like a crab. And as you might recall, the astrological name of the crab is? Cancer. And so basically, the term cancer, if you will, actually was coined by people describing that back in the day of, around 129 or 130 AD. So it was a long time ago that people were making mostly observation, practicing on other things. And it really wasn't until the Civil War where they had to go into action, and there were still barbers doing that. There were very few really trained surgeons to do the only operation of the day, which was amputation.
Yeah, and it did save lives.
It saved thousands and thousands of lives.
Right, because they didn't realize sterility. Now, I do know that they knew anesthesia. Do you know the story of anesthesia, either one of you guys?
Yeah, it was developed by a dentist, I believe, in Boston.
Well, actually, it was a guy from Georgia, rural Georgia, before him, and there was a big debate, but the dentist got the credit.
Oh, really? Okay.
The ether dome in Boston, but it was Crawford Long in Georgia who had done 7 years earlier had used ether to drain a boil.
Well, prior to anesthesia, the most important, one of the most important factors of any surgical procedure was speed, because the patient was being subjected to horrific amounts of pain. And oftentimes they may have been better off after the surgery from whatever surgical disease ailed them, but there was such a trauma that they recalled from having this happen that they were scarred for life, if you will, in more ways than one. Yeah. And so with anesthesia, it took that out of the equation. It also made everyone else a little bit more relaxed because the surgeon didn't have to worry about
speed and the pain. You didn't have to hold the patient
Very
down.
much so up until then, I'm sorry, but it was a shot of whiskey and a bullet that you would chew on. And again, these amputations, most of them, unfortunately even by the Confederate side, didn't have the anesthesia. They did have ether, but they ran out of it. And so speed, again, was it. Speed for purposes of pain and speed for purposes of blood loss. And they could literally do an amputation under a minute and have it taken care of with under a minute. And it was remarkable what they were able to do, but it was the circumstance, not necessarily the best.
Right. Now, sterility came in after the Civil War.
Yes.
What's that story?
Well, I pretty much Lister and his identification of bacteria that was involved in things such as, again, a badge of honor to a surgeon was how bloody his drape was. And a badge of honor how good a surgeon was, the more blood on his apron, the better he was because he had more experience. Not recognizing that all of that carried with it the bacteria and everything that went along with it. And so and then when folks actually realized that, they began to do some surgery with, I don't remember what the antiseptic they sprayed in the room as they did the surgery, but they actually saw wound infections go down for the first time.
I've actually heard that's where the white coat came from, because once people realized that dirt meant a lack of sterility, doctors formerly and surgeons wore black or dark colored clothing. And once they realized that, boy, it kind of makes a difference how dirty one of these guys looks, let's put a white coat on them and see how dirty they look, because that probably means they need to wash up.
So we have got questions, and I'm going to borrow this one because this one isn't working.
Sure.
A woman from Rapid City with degenerative back disease, is it better to have surgery or hope the pain resides than to avoid surgery and keep taking pain medicines? Back surgery, that's a tough question. It's a good question. Answer.
Well, there's no answer that is straightforward. It's one of the 50-50 things. I myself have had some back injuries, and I know exactly her predicament and the discomfort. I was told by very intelligent neurosurgeons that with even a herniated disc, there's about a 50% chance that'll get better with physical therapy in time if you can put up with it, provided you're not losing muscle activity or actual strength. And that once you do surgery, that's it. You really it's harder to fix it the next time and the next time and the next time. So I certainly understand the difficulty that this patient is suffering. And most neurosurgeons would tell you to try absolutely everything before. Wouldn't you agree?
Yes. Yeah.
Well, and generally pain is not the reason for surgery. It's loss of neural function that brings you to it.
A wise surgeon once told me that if you operate for pain, that's exactly what you get.
You're going to have more pain. You do not want to
The
operate
only one
for
that has pain is the surgeon.
Yeah, there's a lot of pain and suffering afterwards. We've got some pictures that I want to start with. This is a picture of an operating room. Any comments about what do you notice about this, Jeff?
Well, the first thing that kind of is striking to folks who've never been in an operating room is probably, what are all those people doing in there? This individual here,
touch the red button.
Yeah, there we go. This individual here and here, they are the surgical nurses. They are responsible for kind of taking care of the patient, taking care of a lot of the logistical issues that come into the operating room. And you'll notice that they are not, do not have these blue gowns on, so they are not scrubbed. So they can leave the operating room to go get different instruments, different materials, etc. This person right here, this is the anesthetist, or the individual that's going to be administering the anesthetic. And you'll notice right here, that screen contains all of the vital information that is obviously the most prominent piece of equipment in his view. This machine is what administers the anesthetic here. And then these two individuals here are the surgical technicians. They're trained in...
Mark them a little harder.
There we go. This one and this one. They're the surgical technicians. They're trained in understanding all of the different instruments available to the surgeons. They're trained in some of the anatomy, and they assist the surgeon in the operation.
So that's a busy room. And then, of course, this is the patient.
Yes, that's the patient is...
We know which one is the patient.
Right there.
So that's good. No, one that's lying down. We now know that it was Susan Cambo who correctly answered our question. Thank you, Susan, for your answer. The book will be in the mail shortly. So we'll be talking about that later. So let's talk now about the advance this history thing, and let's talk about aseptic technique. A lot of the things that you show here is sterility. I mean, and of course, right here in this town, we have 3M Medical, which makes a lot of sterile things. Explain some of the things that 3M makes. And I'm not trying to promote 3M or anything, but they make these gowns and this tape, and what's that all about, Gary?
Well, many of the products that we use throughout the nation come from actually this plant here in South Dakota. It's pretty cool. They make types of tape that are adhesive but don't take your hide off when we pull it off. They make, as you mentioned, these yellow IO bands, they're called, that are clear tape that are impregnated with an iodine that, again, will help reduce infection.
So, I mean, they plaster it on the skin,
right
and then you cut
right through it.
It's sort of like a giant piece of saran wrap with an adhesive side that goes over the patient's where the operating field is.
Yeah, it's amazing.
They help us with a lot of their dressings that we use to put and do dressing changes. All of this, of course, made absolutely sterile and absolutely reliable, and that's why they have such a great name in this area, and certainly throughout the United States.
One of my favorite products is something called a Steri-Strip, which is a small adhesive tape of variable sizes that I always enjoy putting over a surgical wound, because it just gives me a sense of satisfaction. And whenever I take anybody's staples out or remove their stitches, I always put a little Steri-Strip on there, and I said, these are made right here in Brookings.
Well, and not only that, as far as his comment about it, it makes them feel more secure. It makes the patients feel secure.
Right.
A lot of the surgeries that we do, we put stitches under the skin. They don't see it, and it's strong enough to hold, but these little Steri-Strips actually bring the edges a little bit closer, but it actually also gives a little bit of, how would I call, security to the patient that it's not going to open. I always joke with my thyroid patients that After surgery, there'll be no stitches. It's all underneath, and you'll have little pieces of steri-strips across your neck. And I tell them they can turn left, they can turn right, but don't look back, because if those tapes weren't there, their head would fall off. It never, of course, never does. But it always gets a smile on their face, and it really, you know, if anything, they then also see where it is, and they know exactly what's been done. And the nice part is those fall off typically within a week or so, and have really, I think, add additional comfort to the patient when they go home that that's not going to fall apart.
I will also say that the Littman stethoscope is put together right here in this plant. The Littman cardiology scope, which many of us use. I don't know if you use a Littman cardiology scope, but that's my equipment.
Been a year or two since no. We use stethoscopes. I don't know about the cardiology stethoscope.
Okay.
Someone asked me once, I was carrying a stethoscope, and it was an internal medicine physician, and they said, "Do you have privileges to use that?"
Yeah. So, well, let's talk about the differences between surgery and internal medicine. I would say that internal medicine, the physicians of old, the American College of Physicians, my club, you do residency in internal medicine. Some of us go out and practice. Some people teach for a while. And then some people would go into rheumatology, cardiology, nephrology, all of the subspecialties of internal medicine, geriatrics, which is a subspecialty of internal medicine, and family practice. But what are the specialties of surgery?
Well, I can tell you that I came up with some 20 different types of specialties in surgery today, of which general surgery, what we're both general surgeons, is the precursor for most of those. And out of those 20, well over half of them will require that you do 5 years of general surgical training first before you're allowed to do that particular specialty.
Thoracic surgery?
Thoracic surgery, vascular surgery, pediatric surgery, colorectal surgery. All of those do have a prerequisite to do 5 years of general surgery first. There are some disciplines, urology, neurosurgery, ENT, ear, nose, and throat, in which you would do probably 2 years of general surgery and then complete your residency in those specialties.
Oh.
But really, and now the new thing is, and again, because of the change in the way we're training residents, more and more are choosing these specialties, and general surgeons are becoming fewer and fewer. I had mentioned to some students earlier, the United States produces about 1,000 general surgeons a year. Only 200 or less go into general surgery for the entire nation. And right now,
we have one.
Yes.
We have two in Brookings.
Yes, you're very fortunate.
Oh, and
I need to tell you that those 200 have to be spread across the entire United States to fill over 1,000 to 1,500 retiring every year. And it doesn't take a genius to figure out that the math doesn't equal.
I'm just trying to think about whether we should talk about anything else in this video here. Jeff, you picked this picture because?
Sure. A little bit later on, we're going to be watching some video of a surgical procedure where you may hear the term, the count is correct. And if you notice, look at all these things. I mean, there's probably 40, 50 instruments right there. And every time someone goes through an operation, those instruments are counted before and after to ensure that nothing is left behind. Right. Not only the instruments, but you can't quite see them. They're right here. These are the sponges that we use in an operation. Those are also counted. Those are actually counted twice.
Every needle.
And every needle, yes. And every blade. So I mean,
that's why you've got those nurses that count all those parts.
That's correct. But I mean, you just when I'm closing a wound, that's one of the things I enjoy hearing most is
sponge count is correct.
The count is correct.
Lap and instrument count is correct.
Yes.
Yes, and I want you to know, I go into that same operating room and do colonoscopies, and I get done, and they say, colonoscope is correct count.
Well, and I need to also share that it isn't just that at the end of the case, that we now have taken such precautions to prevent error, that we have what's called surgical timeouts. I find it interesting. I did not know Jeff was a pilot, and pilots and surgeons are very much put in the same group where we have our checklists before we do things. And surgery, one of them is a preoperative checklist. And we will, with everyone in the room, call a timeout and make sure everybody knows not only who we're operating on, but what part of the body we're operating on and which limb, left or right. All of it in an attempt to improve outcomes and improve patient safety.
And there's plenty of data that suggests that the timeout does have some impact on improving outcome.
Yep.
So these are just like counting the wheels on the airplane before it takes off, or whatever they
Whatever they
count
do,
on an airplane.
he would know better than me.
Yeah.
Yep. People sometimes avoid going in for a routine checkup with their physician for fear something serious like cancer will be discovered. The truth is, though, that the early detection of a problem has the best chance of a positive outcome.
This is a huge surprise to me to have thyroid cancer. I went in for just kind of a generic
Well woman.
Yeah, well woman, that's exactly right. And I went, what? I've noticed, just because I'm more cognizant of it now, I went, well, it doesn't look like anything. And now when I look in the mirror, I can see that there is a little bit, yeah. Oh, yeah. It's harder to swallow.
Okay.
I
And
do
any
have-
changes in your voice?
Hoarse.
Okay.
A little.
That's what
I have to
people
clear my
understand.
voice more often than I ever have before, and there's pressure in my. It's not an earache, but it's like
Different.
yeah. And I thought it was related because I've always had allergies, so I thought it was related to my allergies. I thought,
We make an incision on the neck, a couple of finger breaths above the collarbone here, and then there's a few different muscle layers that we need to open up in that area, and then we start on the left side because even though it's in the middle portion, it's kind of off to the left
Okay.
on that side. And so we'll take the left side up, go around the vessels at the top, find the vessels in the middle as well as on the bottom part. Be sure that we can find the parathyroid glands, which are the glands on the back side that regulate your calcium level. We need to make sure that those are left inside because otherwise she's going to have problems with calcium regulation. Then we'll move over to the right side and do the same thing over there. Afterwards, basically what we do is we make sure that everything is nice and dry. There's no evidence of bleeding, nothing concerning there, that her parathyroid glands are good. And then we close up your muscle layers.
Okay.
Then after that we put sutures in the skin. Everything will be on the inside, and then there'll be some glue over the outside.
oh, just glue on the
Yep,
outside.
just glue on the
really?
outside.
Oh.
Now it's considered to be a one-day procedure. It's not considered to be an inpatient procedure. However, we do you later so that we can keep you overnight
for observation.
watching you
Okay.
because there is a risk associated
bleeding.
with thyroid surgery, with bleeding. And if there is bleeding in terms of a hematoma or a big blood clot, that can close off your airway
Sure.
and kill you. And
Right.
so we want to be sure that we're able to catch that very quickly.
And I know you've told me before, but in my anxiety, I had forgotten the prognosis of this is good then?
Yes, the prognosis of papillary cancer is very good.
Oh, good. Oh, good. I want to be around a while more.
Absolutely. Absolutely.
Great story, and we actually watched the thyroidectomy, and you were part of the surgery with Dr. Wee.
Yes.
So we have up on the telestrator right now thyroid. Can you, Gary, walk us through what this is all about?
So this young lady had a diagnosis of a very common, I believe it was papillary cancer, a very common cancer of the thyroid. The thyroid will be, and I tell folks when they think about the thyroid, I tell them, think about saddlebags thrown over a horse. And the horse is your windpipe, and this is your right saddlebag, and this is your left saddlebag. And that typically these saddlebags, then when you think of a horse, doesn't lay on the front, or I'm sorry, the back of the horse, it lays on the side of the horse. And regrettably, some of these nodules, if you will, that can be abnormal, can get fairly large before we can actually feel them from the front because they're hiding posteriorly. They're going toward the back.
They're behind.
Behind. And once we see it or feel a nodule, it doesn't automatically mean cancer. All of us, Jeff will tell you this too. Jeff will tell you this too, that in a diagnosis of cancer, I tell again my patients, if the Lord told me, Timmerman, I've got good news and bad news. The bad news is you're going to have cancer in your lifetime, but the good news is I'll let you pick it. I would pick thyroid cancer every time, because even today, even most of the metastatic thyroid cancers are curable, and without losing your hair and without horrible radiation treatment. So basically, if in fact this turned out to be a cancer, and the most common is what we call papillary. Again, in the world of surgery, we say be happy if it's pappy. And that means that it has a wonderful cure rate. It does have a cure rate of over 90%, even probably 95%, pretty much irrespective of the size. So in a surgery that would involve a nodule that we would be suspicious of cancer, we would typically, if we knew at the time of surgery or preoperatively, confirmatively, that that was a cancer, we would tell the individual you'd probably do best to have, at the time of surgery, your entire gland removed. Whereas, if you're not sure, we would take out a portion of the gland and probably remove this part of the gland and send that down to pathology. And then pathology may not give us that diagnosis. They may cut that in half and say, we can't tell for sure if it's cancer. And yet, when those patients go home, I always tell them, and I'm sure Jeff does too, there's a chance that when the final word comes back, it's cancer. And then it's how much. And if it's a small amount of cancer, usually less than even 2 centimeters or 1 centimeter in size, we may say we're done with surgery. Yep. Whereas if they say this is all cancer and we're worried about it, then we would go back and take the other side. Okay. Whereas again, if it was the first time and they told me it was cancer, I'd probably take both sides.
Okay, so now I'm going to take this question. Behind the thyroid
are 4 little glands.
These little parathyroid glands. So you remove the whole
gland, and you have to leave the parathyroid.
So how do you do that? I mean,
so again, it's the same story of para. I tell people, and I'm not 100% sure, but I think it has to do with paras. I tell them means next to. So I tell them the parathyroids are the next to thyroid glands, and at the bottom of the saddlebag, toward the horse's tummy, that's where these little parathyroids live, 2 on each side. And quite frankly, all you need, and again, I jokingly tell patients, but confidently tell patients, the Lord knew we were going to do thyroid surgery, so he gave us 4 parathyroids so that the surgeon wouldn't be terrified about it, because these parathyroids are about the size of the end of your pen. And in a neck, the end of your pen is like a ballpoint pen. The size of that in your neck is kind of a needle in a haystack. And so if you are comfortable finding those, they usually hide in a certain spot. But parathyroids are notorious for moving all over. They can move high, or they can move low, or they can even sit on top of the heart. And I've taken several off of the heart. So they are themselves an interesting part of the whole dissection. And you're right, we have to leave at least one of those behind.
But do you have to leave them there? I mean, my cousin who had parathyroid surgery had his
in his forearm.
In his forearm.
Correct. So I also, again, will tell them, if you have a condition in which, thankfully, 85% of patients with parathyroid disease, not thyroid, parathyroid disease, have a solitary or one gland that's big. And so if you take that out, it takes care of their problem.
Right.
The other 15%, for purposes of simplicity here, have anywhere from 2 to all 4 involved, of which case then you'd like to take all 4 of those out, but you can't leave somebody without a parathyroid.
Or your calcium goes all out.
Correct. So we take one gland and we cut it up, and I tell them we're planting corn, and we're planting it in their forearm. And now, if it grows and is a problem, I can do that operation on their forearm, even under local anesthesia, and I never have to go back to the neck again.
Yeah, Dr. Timmerman makes a good point about the Lord knew we were going to do thyroid surgery, parathyroid surgery, and gave us 4 4 parathyroid glands. I heard a cardiac surgeon mention that the Lord knew we were going to do bypass surgery, which is why he gave us a specific artery in our chest.
The internal mammary.
Yes, to use it. And there are many examples
of why the Lord did these things. That's absolutely amazing. Well, you know what? We've got some pictures, a story of gallbladder surgery done with the robot.
Yes, the
and
robot.
I'd like to go to that. Jeff, you looked at some of these pictures. The first picture, tell us what this is all about.
So this is the initial portion of the operation. The patient is asleep, and we're placing the sterile drapes on top of the patient and exposing what we call the surgical field, the small portion of the body that we will be operating on, or it will contain our incisions.
So, and you could see he was putting a sterile handle so he can direct the light without losing sterility.
Right, yes.
All right. So there's one, what's the next picture?
Okay, so they're positioning the table, and then they've moved the robot, the surgical patient cart, into position. Those arms are what will control the instruments that are actually placed inside the patient. Here, Dr. Wee, my partner, is positioning the instruments. They're actually inside the patient now, and she's watching on the screen. There's a camera that's inside the body that she's using to position or watch the position of the instruments.
Wow.
And now she will take her surgical gown off and proceed to the to what we call the surgeon cart, which is where we manipulate the robot. So that screen right there is actually a view of what's going on inside. That screen is what the members of the operating team see. What the surgeon sees when they're manipulating the robot is actually a 3-dimensional image within the surgeon cart. So the gallbladder's been dissected, and what she's doing here is she's placing clips on the small duct that connects the gallbladder to the main bile duct. And she's divided that structure now, and she's removing the gallbladder actually off of the liver. And what she's using is an electrical current developed by a guy named Bovey. It is not cautery, it's actually an electrical current that passes from the instrument through the tissue through a grounding pad on the patient. And that's the way the gallbladder is removed off the liver. Because you couldn't just cut the gallbladder off the liver because it would bleed. That instrument seals the tissue at the same time.
And she's in a cart, completely separated from the patient.
Separated.
And she moves, and it triples the.
Yes. What she does is she's looking into a almost like a hood, and there's a screen for each eye. And on the tip of the camera, there's 2 cameras. So that instills three-dimensional. It adds depth and gives you a depth perception.
I can tell you I think the year was 2001, it was called Zeus before it was called Da Vinci. Oh. And the original Zeus was rolled out at a College of Surgeons meeting, and they had the surgeon at that booth in San Francisco, and the patient in Paris, France.
Wow. And
he did the operation on the patient in Paris, France, in San Francisco, just to show that you didn't have to be there.
And we're going to talk about that. We got one more film. Let's look at the gallbladder being removed.
Right.
So
the operation is complete, almost. The gallbladder's been removed off the liver. They're moving the robot out of the way, the patient portion of the robot. Dr. Wee is re-scrubbed, and they hand her this instrument that extends a small plastic bag. She's inserting it into the abdominal cavity. There's layers of the abdominal wall, each with a small hole in it. That's why it takes a little bit of finagling to get it in, because there's a defect in the skin, defect in the muscle, and you have to find both of those defects. Now she's got it in, and she's going to advance it and then open up the instrument, which extends the plastic bag. That other instrument that's in her left hand is manipulating the gallbladder. It's still on the gallbladder. She places it into the bag, which is what she's doing right now. And then she will tighten up, cinch up the plastic bag, and pull it out. And it's really to protect the skin from the potentially diseased organ that you're removing.
Infected gallbladder that you may be removing.
Yeah.
So you're telling me that the guy in San Francisco removed a gallbladder on a patient in Paris. Those are great ideas. a surgeon in Sioux Falls could do surgery in Brookings without a surgeon present, well, probably with a surgeon present. But
Understand, most of this came from military and trying to figure out ways to get to the wounded people on the battlefield without sacrificing your one surgeon that could serve 20 to 50 wounded people. And so they came up with these sorts of things to think outside the box. And how could you have your surgeon someplace that could be doing something on many people? And they took it one step farther than we would ever do on a military battlefield, at least at this time. But as we speak, there are companies coming up with that very same kind of technology, but in a much smaller fashion, that might be able to reach into an abdomen on a battlefield, put in by a med tech with a surgeon off in another place, and do some things to control bleeding to get that patient, internal bleeding, to get that patient to a MASH hospital.
right. You think this is something that will happen in South Dakota, rural health, person having an
That's a
acute
great
illness?
question. I don't know.
I'm not. I mean,
Thought of that.
it brings up an interesting point about the robot draws on what's called a laparoscopic or a technique where you use a camera to watch small instruments inside the body.
Yeah.
But the surgeon manipulating these instruments still has to know what to do and what's going on in the inside, because occasionally we need to sacrifice the better visualization, the more precise instrumentation to still touch and feel the things that we're doing.
Right.
And a surgeon will always have to be in the room.
Right. Does the data say that the Da Vinci saves lives, reduces?
It's just a tool. It's a tool that really builds on some very fascinating technology with visualization and instrumentation.
So it has its place, particularly now, in places what we call very tight space, where it might be hard to get in even with standard laparoscopic, and certainly very difficult for our hands to get in there.
So, I mean, if you do a movement like this outside, it may be doing a tiny little movement.
Absolutely.
There.
Plus, it takes away your shake.
Yeah.
So a lot of us have an attention tremor, and it's gone when you use this. So you could be shaking here, and your hand looks steady as a rock inside the camera.
Wow. But the shake really doesn't separate a good surgeon from I mean, you know,
No.
that.
Hey, Rick, I want to point something out.
Yeah.
In yours and my lifetime,
Yes.
we went from open operations, everything was open. And I can tell you by the year I finished, which was 89 or so, I went to take my boards, and I went to San Francisco, and I met a gentleman who said, "Are you going to take gallbladders out with the laparoscope?" And I said, "What's that?" And I realized then I was already not trained. And so in my lifetime, we have seen surgery so changed by not just what we can do with our hands, but what we can use with technology. And now to where we're doing Da Vinci things, and we're talking about all these other things. You wonder why people like surgery, us surgeons.
Yeah.
It's something new every day when I come to work.
I have to say it's the same way with internal medicine. I mean, it is in an evolution right now. And we were talking to students earlier before the show. It was great to hear you say that a really good surgeon, I've said this many times, is an internist first and knows the head and neck and the heart and the all of that internal medicine stuff as well. And then you know when to go to surgery or not.
Well, it's a rare opportunity and relationship between a patient and a surgeon, because we're having such a profound effect on their physiology by doing the things that we do, making incisions, dissecting tissue. I mean, it is incumbent upon us to understand intimately those details because we're affecting them profoundly.
More importantly, and exactly what he said, is the reverence we as surgeons have that patients allow us to do this. And it's remarkable because it's, in my eyes, one thing to do something to them from the outside, but when you let somebody do something to you on the inside and put literally for those moments your life in the surgeon's and God's hands at that moment, that's a trust that we just never, ever get over. You can't get over it.
You can't betray it either.
Correct.
I tell patients a lot that I want you to have a wonderful, perfect outcome just slightly less than you do.
Yeah.
When you want a perfect outcome.
And I am on your side.
Absolutely.
We have questions. Woman from Sioux Falls, my husband had surgery for a fractured hip, and after surgery he became incontinent. Is this a common problem, and why does it happen? So, incontinent after hip surgery.
There are untold potential complications to anesthesia and surgical procedures.
Some of it also could be, and it depends, is it long-term incontinence? Could it be that he may have had a problem with his prostate before surgery, and surgery will aggravate a lot of conditions that we're just getting by,
Right.
and then we do something and it makes that condition worse. It may have, again, as he mentioned, something to do with the medicines. I wouldn't necessarily directly relate that to the hip surgery, but I would certainly tell them they should get it checked out.
Yes.
Well, and I would look at the medicines that the patient's
Correct.
on now compared to before. Certainly, the narcotics that you use for
Yep.
pain blows your ability to pass urine normally. It
Yep.
obstructs things, things can get infected.
Well, surgery changes a patient's body, and that's a fundamental aspect of surgery, and they're different after they have the operation, and how they respond to medicines and things may be different.
I got a question.
But that certainly is a rare complication. And
That's not a common deal. Well, I have to say that that in my patient's age bracket, which is very geriatric, that you blink at them twice and something can fail. So let alone cut open their hip and saw around on the bones and
Right.
drive a spike through into the whole 9 yards. I wanted to make it sound pretty bad. But the point I'm making is you do little things to these people and they change. And bladder is one of those things that can get into trouble. We have a question about using lasers for low back pain. Now, I'm going to ask you about lasers. There's a lot of laser surgery done. Laser is used as a knife, or it used to be used for a knife, or it's used in...
I'm shaking my head. Have you ever used a laser very often?
only to like point on a screen
Correct.
or things like that, not in an operator.
When we did the initial gallbladders, they always would say, I want the laser gallbladder. And there were some laser technique that they used, and they found, as you saw on the video with the gallbladder, that cautery works just as well, far safer, and far cheaper. And so a lot of folks would say, I want that laser gallbladder, but we know what it is. It's just the standard. So in our world, no, we don't use it as much. Now, I know that ophthalmology uses it on the back of the eyes to do certain things. I know that plastic surgery will do certain types of laser, certain radiation to do peels on the face for skin lifts and that sort of thing, but not so much in our world.
Urology, does too. I mean, they use laser
Inside the bladder.
Inside the bladder and on the prostate.
Correct.
Laser, but I'm not necessarily certain that it's been shown to be any better than the old
Not
stuff.
in our world.
New does not necessarily mean better.
That's true.
We have a question. That was it. So the other question that I would have is, I had a patient who had knee surgery, and following that surgery, the patient became confused, and we've got about 30 seconds left, and was confused for 3, 4, 5 days, and I thought a stroke. I mean, I did everything under the sun, and he came out of it. And it happened again the next time he had surgery. Mm-hmm. And it has to do with the narcotics in that guy.
And the tolerance.
Some people are really sensitive and others are not.
Absolutely.
We have to go to this. Now for the answer of tonight's Prairie Doc quiz. The best treatment for an infection that is collected into a red, hot, swollen, painful, inflamed boil is antibiotics and cold compress, yes or no?
No.
No. A knife into the pocket of pus and hot compresses?
Yes.
Correct. Massage and crystal therapy? Probably not.
Probably not.
The answer is number 2. Drain the wound, apply heat, antibiotics are less important. And again, Susan Campbell from Rapid City correctly answered our question. Susan, thank you for calling. We'll send that to you. We'll be back right after this. Sorry. Flu.
You're not you when you have the flu. Get vaccinated, because stopping the flu starts with you.
About 150 years ago, 1 in 4 fighting in the Civil War died, amounting to some 620,000 deaths. 2/3 were due to disease, not injury, and a full half of non-traumatic deaths were from diarrhea illness, unknowingly due to the contaminated water. The remaining non-traumatic deaths were from respiratory illness, particularly lethal because 90% of the soldiers were weakened by chronic diarrhea and malnutrition. That said, 1/3 of the deaths that came from injury would have been worse had it not been for the surgeons that became experienced during the Civil War. There had been radical improvements in weaponry at the time, with new rapid-fire rifled muskets, which caused cone-shaped bullets to spiral, giving an impressive accuracy at a 300 to 500-yard range. In the face of such deadly weapons, smart soldiers hid behind trees and rocks and earthworks, but too often had exposed legs or arms. It's no surprise limb injuries accounted for 70% of all wounds. These bullets tore enormous, easily infected wounds with shattered bones, pieces of clothing, and non-sterile skin pulled into those wounds. Most trauma surgery had to be performed within the first 24 hours after injury in open-air field tents. The value of sterility was not yet realized, and there was no understanding of clean instruments, clean wounds, or even clean hands. The world would have to wait 10 more years before Joseph Lister popularized sterile surgical technique, and before the value of clean water was understood. One war reporter wrote, "They would work for days without washing. As he waited for the next man to be placed on the table, the surgeon would stand back, holding his knife in his boot or even in his teeth." Another description: "The surgeons and their assistants, stripped to the waist and bespattered with blood, cut and sawed away with frightful rapidity, throwing the mangled limbs on a pile nearby as soon as removed." Without sterile technique to repair a wound, amputation actually provided a better chance of survival. Although there was no sterility, anesthesia was available during the Civil War. Ether had been discovered in the 1840s, and by 1861, chloroform became popular by field surgeons because it was less flammable, less nauseating, and more portable. Records indicate that during the entire war, general anesthesia was given 80,000 times, with only 43 recorded anesthesia deaths. The reported screams coming from surgical tents were not from anesthetized patients, but from wounded soldiers about to have surgery. Then, as the war ended, some 15,000 experienced surgeons returned to their home communities all over the United States. Who would have thought that from the horrors of war, life-saving knowledge of anesthesia and surgery would spread throughout this country? A heartfelt thank you to our special guests, Jeff Johnson and Gary Timmerman. You both brought great insight to our discussion tonight. Flu cases continue to climb as the season progresses. We're right in the time when historically flu cases really take off. If you haven't received your flu shot yet, don't delay. Get your flu vaccine now to reduce your chances of catching the flu bug. So from all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
This part of the country know that winter brings many special concerns to everyday life. Staying healthy is even more of a struggle during this time. Winter health, next time On Call with the Prairie Doc.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
And by
The South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota,
additional funding is provided by
Aberdeen Asthma and Allergy,
Avera Heart Hospital,
Brookings Health System,
Dakota Allergy and Asthma,
Dakota Care,
Orthopedic Institute,
Physician Care Sanford Clinic Community Service Committee,
Swiftel Communications.
and Vance Thompson Vision.
Closed captioning for On Call with the Prairie Doc is provided by
Avera,
Brookings Health System,
and Fishbeck Financial Corporation.